Hey guys, hemochromatosis is a very commonly tested condition and it will come up in a variety of different organ systems, so you'll see it many times as you go throughout pathology, but I really wanted to make this video to help you have a good overall understanding before diving into more specifics. Commonly, hemochromatosis is going to be covered in liver and GI sections, but it's a very highly pleiotropic condition that can affect virtually any organ system. In the most simplistic view, hemochromatosis is a state of excess body iron causing iron to become deposited in tissues. The actual deposition of iron in tissues is termed hemosiderosis, and then the eventual organ damage is known as hemochromatosis. Remember, when talking about cellular injury in pathology, a common cause of this damage is due to free radical formation. Excess iron can generate more damaging free radicals, such as things like hydroxyl radicals, which is one of the most reactive via the Fenton reaction. The Fenton reaction is where iron Fe2+ and hydrogen peroxide is going to generate Fe3+ as iron is oxidized, and the hydrogen peroxide is split into a hydroxide and a hydroxyl radical. These free radicals can then cause injury to the cell through lipid peroxidation, stimulating fibrosis and collagen deposition, and also directly damage DNA. Hemochromatosis can either be a primary or a secondary disease. Primary hemochromatosis is also known as hereditary hemochromatosis, whereas secondary hemochromatosis is secondary to another primary disease. Secondary hemochromatosis can be due to things like chronic blood transfusions, like a patient with beta thalassemia major that relies on blood transfusions, sickle cell, etc., or it can be due to excessive intake of iron, like dietary supplements, or some liver diseases like chronic liver disease and porphyria cutanea tarda. Either way, there's too much iron that's brought into the body, and since there's no way for the body to excrete iron except for blood loss, you get buildup. Remember, the body has no way to excrete iron. It's due to excess either absorption or intake of some kind. In hereditary hemochromatosis, primary hemochromatosis, it's very important to know that it's an autosomal recessive condition. The most common mutation affects the HFE gene, but it can also be due to mutations in the transferrin receptor or mutations in the actual hepcidin gene. The most common HFE gene mutation is the C282Y gene. Also, there is an H63D mutation, but the C282Y is the most common. The C282Y allele has a carrier frequency of nearly 11% in some European populations, making it one of the most common genetic disorders in humans, although penetrance is relatively low. So people that carry it don't always express it. The HFE gene is on chromosome 6 and codes for the HFE protein, also known as the human hemochromatosis protein. So for the purposes of this video, we're going to focus on the mechanisms of hereditary hemochromatosis, since the mechanisms for secondary hemochromatosis are fairly straightforward, like excess blood transfusions. So the intestines are the only way to control total body iron stores, since there's no way to excrete it, as I mentioned. In hereditary hemochromatosis, there's an excess absorption of iron, leading to net iron overload. So let's start first with normal physiology. Your dietary iron comes in and is absorbed in the duodenum, with some also being absorbed in the upper jejunum. Iron can then come into the diet as either ferric iron, which is Fe3+, but it must be reduced to ferrous iron, which is Fe2+, before it can enter the cell through DMT1, the divalent metal transporter. The actual reduction of iron is done through ferroreductase. Also in the diet, heme iron can be taken in, and that can be taken directly into enterocytes through a heme transporter before being broken down to iron. The main regulator of iron absorption is through hepcidin, which is a protein encoded by the HAMP gene. Hepcidin is secreted by the liver, and the two main stimulants for hepcidin production are high iron, through negative feedback mechanisms, and inflammatory cytokines like IL-6, because IL-6 and other cytokines are acute phase reactants that cause the liver to have different reactions. One of the acute phase proteins is actually hepcidin, trying to limit available iron for pathogens. Hepcidin then circulates and binds to ferroportin channels, which closes it, which is on the basolateral side of the enterocytes. This inactivates it and internalizes ferroportin. Ferroportin is a cellular iron channel that allows efflux and allows absorbed iron from the gut to cross through the enterocytes and enter the blood. If hepcidin binds to ferroportin and the channel is closed and internalized, no dietary iron that's brought into enterocytes will actually be available into the bloodstream. Be sure to realize, though, that all dietary iron is still being absorbed on the apical membrane of enterocytes through DMT1. Without active ferroportin, though, that iron cannot leave the cell and is ultimately lost in the feces as the mature enterocytes eventually slough off with the internalized iron stored as ferritin. If there is low body iron, then hepcidin levels are going to fall. Ferroportin is now active. Any absorbed iron can then enter circulation through the basolateral efflux channel and circulate to things like the liver. Thus, an excess of hepcidin will lower iron levels over time, whereas a deficiency of hepcidin will cause excess absorption, like in hemochromatosis. So as mentioned, there are three main proteins involved in hepcidin production. The most common adult form of hemochromatosis is due to a mutation in the HFE gene. HFE produces a protein that is also known as the hemochromatosis protein. HFE is an HLA class 1-like allele, so kind of like MHC class 1, and it binds to the membrane of different cells like hepatocytes, and it's a transmembrane molecule that interacts with the transferrin receptor. So it's essentially sensing iron levels. The HFG is going to regulate hepcidin production, and without it there's decreased hepcidin synthesis. Also, there's other genes involved, actually 3 genes that can control hepcidin production. This includes the TFR2, transferrin receptor 2 gene, hemojuvelin, HJV, and the HAMP gene, which actually encodes hepcidin. TFR2 is a very rare cause of hereditary hemochromatosis in adults, whereas hemojuvelin and hepcidin mutations will cause a juvenile hemochromatosis. In general, juvenile hemochromatosis is much more severe and has a higher penetrance and obviously a younger age of onset as opposed to the adult forms. Now that we know how patients with hemochromatosis get iron overload, how will they present? Also, this means how will you have to identify hemochromatosis in a question stem without being told it? What will an NBME test tell you in terms of symptoms? So a key thing to remember is that it takes time for iron to accumulate and cause end organ damage in hemochromatosis. Typically, males are going to present earlier, around an age of 40 years old, when total iron body stores are greater than 20 grams. Women will present later by about 10 to 20 years because of chronic blood loss through menses that acts to delay the accumulation of iron. The most commonly affected organs include the liver, the pancreas, skin, heart, pituitary gland, and joints. Therefore, the classic triad that you'll normally see in questions is the presentation of liver cirrhosis, type 2 diabetes mellitus, and skin pigmentation. Hence the name we give to people with hemochromatosis is bronze diabetics, as there's iron deposition occurring in the skin. Be able to recognize the descriptions and realize that skin findings are highly variable and can be described many different ways in question stems, even being referred to as a slate-colored skin or just a funny discoloration of the skin. It won't always say bronze. Additional findings in hemochromatosis can include a dilated cardiomyopathy. This can lead to things like congestive heart failure and arrhythmias, also hypogonadism and arthropathies. Patients with hemochromatosis are prone to developing pseudogout, which is CPPD disease, calcium pyrophosphate deposition disease, especially in the MCP joints, metacarpal phalangeal joints. When performing arthrocentesis, you'll see rhomboid crystals that are blue under parallel light, meaning they're positively birefringent. CPPD disease, or arthritis, typically presents as a chronic arthritis rather than acute arthritis like true gout, despite the name, although patients can have acute flares sometimes on top of chronic, or they can have an acute synovitis. A major long-term complication of hemochromatosis is cirrhosis due to this iron deposition, and also that can lead to hepatocellular carcinoma. Having cirrhosis is a major risk factor for hepatocellular carcinoma and can lead to a very severe form of cancer in patients with hemochromatosis. And then finally, the treatment for hemochromatosis is via phlebotomy or chelation therapy, which means iron binding with drugs like deferriprone. So be sure to use the drug name to help you remember the different drugs that we use. For example, all drugs for hemochromatosis start with DEFER, with the fer meaning iron, just like ferrous or ferric. So as mentioned, a major cause of morbidity and mortality in hemochromatosis is liver cirrhosis. Cirrhosis is simply the end-stage liver disease where there's chronic inflammation or damage that causes a diffuse bridging fibrosis with regenerative hepatic nodules. Chronic inflammation causes the stellate cells, also known as the fat cells of Ito, to lay down collagen, disrupting the normal liver architecture, causing regenerative nodules between them. This ultimately results in decreased hepatic function. There are many different complications and symptoms that occur in cirrhosis. This includes things like portal hypertension. Portal hypertension will then cause anastomotic varices like caput medusa, rectal varices, and esophageal varices, sometimes which can even be fatal. Also, portal hypertension can cause splenomegaly, ascites, and peripheral edema. Of course, with end-stage liver disease like cirrhosis, you're going to see jaundice, and you also see bleeding complications due to platelet dysfunction and thrombocytopenia from splenomegaly, and clotting factor deficiency due to poor synthetic function of the liver. And this can present as petechiae or purpura. Also, patients with cirrhosis are going to be in a high estrogen state, and the high estrogen will lead to things like spider angiomas, palmar erythema, testicular atrophy, gynecomastia in males, and amenorrhea in females. Patients with cirrhosis will also see neurological effects, including hepatic encephalopathy and asterixis, which is the flapping hand tremor, due to high ammonia levels. Classic lab findings in a person with hemochromatosis will obviously be that of iron overload. Labs are going to show elevated ferritin stores and a resulting low total iron binding capacity. There will be high serum iron and a high percent saturation of transferrin. If a liver biopsy is performed, there will be an accumulation of brown pigment seen within hepatocytes. This brown pigment is hemosiderosis, and you can verify its iron thanks to a Prussian blue stain, which turns iron blue. Prussian blue will help you distinguish iron from lipofuscin. Lipofuscin will stay brown after using Prussian blue. Remember from general pathology that lipofuscin is a wear and tear pigment that is produced as a byproduct of lipid peroxidation over time. Lipofuscin is just a sign of aging. And then definitive diagnosis is made when transferrin levels are over 45 and serum ferritin levels are over 200 in men or 150 in women. Patients typically get MRIs to help estimate the accumulation of the iron in their liver and heart. And then a final thing I wanted to include in this video is to compare and contrast hemochromatosis with Wilson's disease. Both of these will be highly hit-on topics and are very high yield. And as you already know, Wilson's disease is a state of excess copper in the body, whereas hemochromatosis is due to excess iron in the body. So both hemochromatosis and Wilson's disease are due to excess stores of a metal. The major difference between the two is age. Wilson's disease is going to typically present in the teenage years or 20s, but it will never present later than 40 years old. In contrast, most hereditary hemochromatosis, like due to the HFE mutation, will occur in patients over 40, and remember, women are even later, 50 or older. Another fact to keep straight is the mechanism of the two diseases. In hemochromatosis, remember, it's an excess absorption of iron, whereas in Wilson's disease, it's a defect in copper excretion. There is no mechanism of iron excretion besides for blood loss, which is why we use phlebotomy as treatment. So hopefully this video will help you get a really good understanding and foundation, and as you go through the different organ systems, you can see how hemochromatosis affects them, including GI, endocrine, and all those different topics, including cardiac, other things like that.